Okay, everyone, this is Carly Houchin at KHI. Looks like our live stream has started, but we'll give it a couple more minutes as a few more folks join, and we'll get started right at 12:30. But thanks for joining the call. Okay, hello everyone. This is Carly Houchin from the Kansas Health Institute. I showed 12:30, so I'm going to go ahead and get us started with our meeting here. You should see shared on the screen our agenda for today. I'll provide a quick overview of kind of where we're going in the discussion, as well as an overview of some of the meeting materials you should have received in advance of our call today. But before we get into that, I want to ask Jenna Moyer, I think has joined us from the revisor's office, to give us a quick overview of the open meeting requirement. Jenna?
All right, good afternoon. And I apologize if my video is unstable. We're on vacation and the Wi-Fi up in the cabin is not great, but I'll go ahead and get started with the open meetings script. Health and safety concerns, members of the public are not in attendance at this meeting of the Special Committee on Mental Health Modernization and Reform Working Group on Citizen Capacity and Transformation, but full access to this meeting is being conducted by medium of interactive communication, allowing members of the public without cost to listen to the meeting through the use of live stream audio broadcasting on the internet and teleconferencing as available. This video can be accessed on the YouTube webpage by searching for the Kansas Health Institute or the KHI Live channel. The agenda and all documents for this meeting have been provided by the Kansas Health Institute. Additionally, a link to these documents has been provided in the comments section of the YouTube video previously referenced. Each member of the working group and staff shall state their name and title each time the person begins speaking or voting so that the individual can be readily identified by remote listeners. All participants are required to ensure that microphones, phones, or other electronic devices are muted when you're not speaking so that the ability of remote listeners or observers to hear the proceedings is not unnecessarily impeded. Public comment will not be allowed at this meeting. During this meeting, the committee will not recess to a closed or executive meeting pursuant to KSA 754319 and amendments thereto. And each motion, if any, will be clearly stated before the working group votes, and the chairperson will announce the results of the final vote. And if you have any questions throughout the process, just feel free to let me know.
Great, thank you, Jenna. So with that, we'll jump into the business of the day. As a reminder, this group is coming together to put forward recommendations for a strategic plan to modernize and reform the behavioral health system in our state. Our process at this point will be taking one topic per meeting that has been assigned to the group by the special committee. Our topic for today is data systems. So we'll spend some time talking through the recommendations, the existing recommendations that have been developed related to that, as well as addressing some of the barriers that this group has brainstormed in previous meetings as they relate to data systems. To quickly walk you through the agenda on the screen here, we'll get started with some brief introductions here in a moment. Then we will spend the bulk of our time reviewing the document titled WG3 Crosswalk Agency. That was sent out in advance to all working group members. That's probably the most helpful one to kind of have as a reference for today, as we will be looking at the recommendations in that document, again, as they relate to data systems. So following some discussion of those existing recommendations and scoring those on the recommendation rubric that the group reviewed in our last meeting as well, we'll spend some time developing recommendations related to the barriers previously brainstormed. From there, we'll have a few quick administrative items and aim to adjourn right at 2 p.m. Before we get started with some introductions, wanted to quickly remind everyone of the meeting commitments that we had made previously for the group. And that was that we were to come ready to both discuss and compromise. Going to work to keep our remarks succinct and on topic. We're going to ask clarifying questions whenever we need to, and we will work to start and end on time. So with that, I'd like to first ask working group members, want to run through and do a quick introduction so everyone knows who's on the line, and then we have some supplemental experts who have joined the group today as well. And so I will save those introductions for the end. But the first working group member I'm seeing on my list here for a quick introduction would be Kyle Kessler.
Good afternoon. I'm Kyle Kessler, Executive Director at the Association of Community Mental Health Centers.
Great, thank you. Next, I see Denise.
Good afternoon. I'm Denise Sisman, the Chief Executive Officer of Community Care Network of Kansas. We are the primary care association for Kansas.
Thank you. Next on the list, I see Representative Shu.
Hi, Representative Reese Shu, House District 25. You might hear some baby noises once in a while, but I'll be here.
Very good. Glad you could join today. Next, I see Sandra Berg.
Good afternoon. I'm Dr. Sandra Berg. I'm the Director of Behavioral Health for United Healthcare.
And Spence Cohen.
Hi, Spence Cohen with Office of Judicial Administration. I am the Court Services Specialist there.
Great. Any working group regular members that I've missed in that introduction there? If not, I think we're joined today by two supplemental experts that were identified by the group to contribute specifically on this topic related to data systems. So I want to ask the two of them, we're joined by Laura McCrary as well as Chris Swartz. So we'll ask the two of them to introduce themselves, share a little bit about some of the background and experience that they bring to this discussion, as well as would like to invite them if there are any initial recommendations that they'd like to be sure are on the radar for the group, feel free to surface those at this point as well. But Laura, I'd like to invite you to introduce yourself and share a little bit.
Hi, thank you very much, Carly. I appreciate the opportunity to join you today. And I'm not sure that I would be considered an expert, but I'm happy to be able to answer any questions or to provide any level of clarification that might be valuable. I am the Executive Director of KHIN, which is the Kansas Health Information Network, which is the statewide health information exchange. It's been in existence now for a little over 10 years and was started initially by the Kansas Medical Society and the Kansas Hospital Association. It has almost all of the hospitals, 98% of hospitals participating in the state of Kansas, and about 85% of all ambulatory practices. Most of the community mental health centers, many private mental and behavioral health providers participate as well. And it provides data at the point of care for individuals who see multiple providers and need to have records shared between those providers electronically. So I appreciate the opportunity to, again, answer any questions or share any thoughts that might be valuable.
Great, thank you. And Chris?
Good afternoon. Can you hear me? Hello?
Yes.
Okay, good. Sometimes I have issues with my technology here. So I'm Chris Swartz. I'm with the Department of Health and Environment. I'm the Director of Medicaid Operations. So I'm familiar with basically the system that are supporting the mental health services in a Medicaid program. And I welcome any questions. Today, I don't have any recommendation to offer. This is my first time on the group, and I had a very short time to kind of come prepared, so I apologize in advance for that. But I'm certainly here to listen, compromise, and see what hurdles can be removed from our side. So thank you for the opportunity to participate on the work group.
Great, thank you. Any initial questions for either of our experts? If not, we'll jump into the agenda. And would just like to invite both Laura and Chris to please feel free to jump in throughout our discussion today. Anywhere you are comfortable weighing in is more than welcome. Also want to see if we've had any additional working group members join. Representative Bishop, are you on the line? It's like maybe we don't have audio quite yet. Okay, so I will get us started with our first agenda item. First, wanted to be sure to show what the WG3 document should look like. So this crosswalk table here is where we'll be spending the bulk of our time. These are the existing recommendations that the group is reviewing on this topic. When I sent this out ahead of our meeting, I posed the question, have any of these recommendations already been addressed? Or they were developed over the course of the past handful of years or so some of them may not be relevant anymore. And there was one recommendation of those that you're seeing here that I received feedback we did not need to address today. It's highlighted here in red. So tier 1 recommendation on data infrastructure from the Child Welfare System Task Force. Unless there's a specific concern from the group as you are looking at that recommendation, we're going to strike that from our list and spend the bulk of our time discussing the rest of the recommendations that you're seeing here. I'll pause a moment to give you a chance to look through that. Any concerns striking that recommendation from the list that we discussed today?
Carly,
Okay.
this is Elizabeth. My only question is, and I probably was just not listening good enough. Why are we striking it? Is it something that's being addressed elsewhere? Was that the explanation?
Yeah, I would let the working group member who proposed that we not consider this one at this time, would you be willing to share kind of the thought process there?
It'll be awkward if I don't say anything if you're referring to me. So I'll go ahead and start. This was one that I thought, there's currently a legislative oversight committee on foster care meeting. And so really all of the Child Welfare System Task Force recommendations that don't merge comfortably into what we're studying probably make a little more sense. And I mentioned this to the chairwoman of that committee as well. But also, the tier 2 recommendation is really quite similar. And there are other references to the importance of databases in, I believe it's, I wanted to say it was the Mental Health Task Force, but there were other references to these kind of databases. Does that make sense, Carly?
Works for me. Does that address your question, Representative Bishop? Okay.
Something keeps covering up the little mute thing and then I can't see whether I'm turning it on or off. I have one quick question, and does the integrated case management data reporting system have any relationship whatsoever to the need for addressing Medicaid reimbursement policy relative to just the child or the family, the child and the family together. And then what if the child is hospitalized, the family gets no further service on that case? Do you see what I'm getting at? Is there any relationship there at all?
I wouldn't have thought about it until you said that. I mean, that's not something that I would associate with what that recommendation was. But if others see it differently, I'm fine with putting it back on for sure.
No, this is Sandra Berg with United. I agree, Kyle, that it's more around sharing the information across systems on members, not so much their benefits and what is being paid for. Does that make sense? Representative Bishop?
You're muted.
Yeah.
For some reason, my pad, the little touchpad's not working right. Not entirely, but I will certainly, I'm willing to relinquish my consternation, because I think it's just a matter of ignorance, and I'll learn as we go further. Thank you.
No, I think you bring up a good point in that oftentimes parents aren't aware of what is being paid for by the child's medical card. I look at this as services that have already been completed rather than services that are available.
That makes sense. Thank you.
Sure.
Okay. Thank you for that discussion. Would encourage you to have this document, the WG3 crosswalk agency document, available to cross-reference. But what I'm going to show on our screen now is the recommendation rubric document. And this is the same rubric that we reviewed. I can find it on my screen here. It's the same rubric that we reviewed in our first meeting and was developed kind of in consultation or with feedback from the special committee. And what we will aim to do here is go recommendation by recommendation and score each of our existing recommendations for ease of implementation as well as potential for high impact. And we'll arrive at that score just through discussion of the considerations listed under each one. Before we get into specific discussion on ease of implementation or potential for high impact, the kind of recurring question that I'll pose as we look at each of the recommendations, starting with the one that you see on the screen here, Tier 2 recommendation related to information sharing, encouraging the state of Kansas to establish a multidisciplinary approach and share information across and among stakeholders, irrespective of state borders, in accordance with both federal and state laws. Is this recommendation important to what it would take to modernize the behavioral health system in Kansas?
Denise Sisman, CEO of Community Care Network of Kansas. And I do believe that this is an important recommendation as we consider modernization and reform of the mental health system. As we look at that modernization, we are increasingly interested in using a broad array of providers to address the entire continuum of mental health needs, as well as the entire continuum of available mental health services. And so a key component of that is the best way for those providers to work together is to have accessible information that can easily be shared. And so I think that this is an important part to encourage that kind of cross collaboration. Great.
Thank you, Denise. And I don't know if this was the case for others, but your audio was going a little bit in and out for me there. Maybe if you could take a look at that. I think I got the gist of your comments there. but just a heads up there on audio
Okay.
quality.
Thank you. I have that every once in a while. I'll be a little closer.
Great. Okay, so I was watching videos and I think I was seeing nodding as Denise was talking in reference to this being an important recommendation, as part of what it would take to modernize the behavioral health system. So I'll move us directly into discussing ease of implementation of this recommendation. So I'll just start us at the top of the list here, but feel free to chime in whenever. Would implementing, what type of change would this implementing this recommendation take? Would it require a program change, something like a pilot, a program overhaul, or a new program?
Carly, this is Laura. I just wanted to ask kind of what the definition of information is here. Is this medical information, behavioral health information, education information? I mean, what do we mean about information? Because that'll be, I think that'll be really important for us to know as we consider the ease of doing this.
Yeah, and this is from, I believe, the Child Welfare System Task Force. So I think it would certainly include medical information, certainly include behavioral health information, but I would expect that it might also include education records for something of that nature for individuals and for kids as well. That would be my interpretation there.
So, and this is Kyle. I don't disagree with Carly's interpretation, except for the education piece. It's one of the reasons why, for me, that tier 2 recommendation took high precedence over the tier 1 recommendation, because that first tier recommendation is sort of a catch-all. And to think about, and I've seen this, I can't remember the name of the database at the old SRS, but it basically would allow an educator to get into a database for a child who is in the child welfare system and make notes on that child without listing their own name. So it basically became a bathroom wall for this child's a real bad egg, or things like that. Clearly that wouldn't exist now. But I think that what I was thinking of, Laura, when I saw this recommendation was much more along the acute alerts line, where some behavioral health, some primary care, and those kinds of things could be done. Obviously, Kahan's doing it.
It's clarifying. I've modified the recommendation slightly to make that clarification, Kyle.
I think that's very helpful. I think without that clarification, the term information is so broad, it'll be difficult for us to really, be able to get our arms all the way around that.
Great. So to pose the question again, then what would it take to implement this recommendation? Looking at those items listed under consideration.
So I'm sorry to keep on doing this, but who are the stakeholders? What's the definition of stakeholders as well? That'll also be relevant to us in making these decisions.
Would open that question to the group. In the case where we have a modernized behavioral health system, what are the stakeholders that would need access to this behavioral health, primary care, and other information?
This is Sandra with United. When I saw this, I thought of the primary providers of services, such as the mental health centers, the FQHCs, primary care physicians, folks that are working towards that person's health, even, with pharmacy in there as well, too. A lot of things that Kahan's already covering.
Great, thank you.
So does this include payers, Medicaid as well?
It could be I mean, Sandra's Dr. Burke's a better spokesperson on that than I am, because in my mind it could. I mean, but there's also been, as I recall, for example, when we were looking at doing something like this several years ago with the mental health centers, I think that United Optum was the one that was most interested in doing that. And another one of the MCOs said, absolutely not. And another one said, well, we need to send it to our corporate legal team, which I took as absolutely, absolutely not. So, I mean, that's kind of how I would see that as well. But when you start getting into other provider networks or say law enforcement or courts, it's doable, I think, to make it accessible to them, but and maybe at schools as well. But some of it depends, I think, stakeholder depends on, does that mean read and write access, or does that mean write, mean both for some and only read access for others? So, I mean, that's a really, really good question.
So the way KHIN is structured is the data is available for the purposes outlined under HIPAA. So for treatment, payment, and healthcare operations, the data is available. And to me, that would be pretty clean way to do it, is to say that that stakeholders are those who have a treatment, payment, or healthcare operations relationship with the patient or with the person. And then that would include behavioral health. It would include care managers. It would include payers. It would include, the vast majority of people who are actually, speech language pathologists, occupational therapists, all of those folks would be included under there. Who would not be included is law enforcement. And so I think that's an important piece to point out. Education that's not specifically related to the child's behavioral or health conditions, so just your regular high school, 10th grade teacher who has that child in their classroom. So anyway, I would throw that out there, that's what KHIN's requirements currently are, is treatment, payment, and healthcare operations.
And I would second whatever Laura just said. Specifically when you say into the recommendation that it would be in accordance with federal and state laws. So, anything that is beneficiary specific information where you can actually identify the beneficiary, which would be important here if you want to be directing the treatment based on that information, then would have to comply with all of these HIPAA and would fall under those HIPAA requirements. So, and what I'm not quite sure is all of that information is now available to these providers. So what are we trying to accomplish with that recommendation? Are we trying to go further than what is now? Any PCP can call another provider or a CMHC or anybody that needs information, as long as they are part of they're providing the care for that person. It falls under, yes, you share the information. You share that information because it's relevant to their care. Actually, I've seen providers my providers do that. If I go and get an x-ray somewhere, they say, well, we're going to send that information to your PCP. Yeah, that's fine. They don't need my permission to do that. You know what I'm saying? I'm trying to figure out where are we trying to move this forward? What are we trying to resolve? What don't we have? What are we trying to get over with this recommendation? Because I'm not seeing anything that is not currently allowed under the federal or state law, and that is already available to providers to actually direct the care of the beneficiary and have whatever care is needed in appropriate, amount and, whatever is needed for that person.
I would just say, I completely agree with you. The only thing that KHIN does is it makes that information available electronically. So if the individual shows up at the emergency room at 2 in the morning and is non-communicative, they can access the information in the health information exchange to be able to get the behavioral health records for that individual to find out that they actually do have a diagnosis of bipolar disorder, which might not be available for them otherwise at 2 in the morning on Saturday night. And so if you think about what KHIN does, that's really the sole focus of what we do. We're not doing anything that's not already permitted under HIPAA. There's no changes based upon what we do from what HIPAA allows. We just do it electronically.
Okay, well, that clarifies it for me. Then my next question is going to be, I'm aware of KHIN because they are contracting with our agency and I know who they are. but how often is that information exchanged with, is updated into KHIN? Because, for a treatment plan, you're going to need to have, yesterday, what was there, what happened to them, and I need to have it in the system today for the next person that's going to see them today, to follow up on whatever was provided to that person yesterday, either prescription or, or whatever. So how are we trying with this recommendation to make it more interactive, more, kind of real time type of information? If the person was seen in the morning and the claim one, because I'm assuming KHIN is based on claim.
It's not. Yeah.
It's not.
Based
Okay.
on claims. It's we build interfaces directly to the electronic medical record systems.
Okay.
And so the data does come real time into KHIN.
Okay.
So if an individual is at the emergency room, in Seneca, and then drives over to the emergency room in Marysville, the doctor at Marysville knows exactly what happened at Seneca.
All right. So we already have that in that real time kind of information, because we're not depending on somebody building a claim to know that the service was rendered. You're directly tied into the service system for the EHR. At the
That's
office.
right.
Okay. So that would assume that every doctor's office every provider's office would have to be a participant and be tied into that system, in order for this to be, very valuable, or the majority of them would have to, in order to be valuable for the beneficiaries and the other.
That's correct. That's correct. And when I did my introduction, I noted sort of where we are in terms of penetration in the state of Kansas. Most of the hospitals are participating. I would say 98% of the hospitals are participating. Most, probably 80% of the ambulatory practices are participating, physician practices. We do have a number of federally qualified health centers that are participating. I'd say probably at least 60% of the federally qualified health centers participate, probably about the same in terms of the community mental health centers. We have problems with pharmacies because they don't have the ability to actually to digitize the filled prescription information in the same way that we can digitize medical records. But in general, Kansas is pretty well represented in terms of penetration across the healthcare community. I will say that there are those organizations that are currently not participating in KHIN for a couple of reasons. One is they may not have an electronic medical record system at all, right? So if you don't digitize your medical records, we can't actually bring them into KHIN. Right? Your records are still, we can't share that data. So that's the first thing that we have a barrier, is that there still are organizations that do provide care to Medicaid patients that have not implemented electronic medical record systems, or electronic medical record systems capable of having a true interoperability component to them. So that's a barrier, so when you start thinking about what are the barriers, you've got organizations that have never digitized their medical records. So that would be a barrier. And there's a cost associated with that, right? I mean, there's a cost. You've got to buy an electronic medical record system. You've got to build interfaces to KHIN. KHIN has an annual fee. Everybody pays a small annual fee. For behavioral health, it's $100 a year per licensed behavioral health provider. For doctors, it's $200 a year per licensed prescribing provider. For hospitals, it's based upon their inpatient and outpatient volume. So in order to actually keep KHIN going, everybody pays a little bit. It's not funded by the state. There's no federal or state funding that comes into KHIN to support it.
Can I make a couple comments as well, maybe, Carly? One, maybe, and when one's a question for Laura. It's kind of at the 4-foot level of the swimming pool. So even if pharmacies aren't digitizing their records, by having the prescribers, whether it's the CMHC or FQHC or the hospitals, you still have an indication of the medications that the patient is on. Would that be fair?
That's correct.
So then, jumping right on into the deep end of the pool, I suspect what keeps the rubric moving is whether or not we could make a recommendation that providers licensed by the state of Kansas be mandated to be on KHIN, because when KHIN has, so we have this kind of database. This is actually a pretty old recommendation. This goes back, I know it was re-mentioned in the Child Welfare System Task Force, but this actually goes back quite a ways. And then the one that we got rid of was, again, the big, huge catch-all. Can't we have something for all foster kids that everyone can access? But this would be more along the lines of whether a mandate is needed if you have a state license, whether as a CMHC or other provider. Is that fair, Laura?
Yeah, and I will share that in the past, there has been sort of a system of carrots to get providers to participate. And that really has come from Blue Cross and Blue Shield of Kansas. They do provide incentive payments to doctors and others who see Blue Cross and Blue Shield patients to participate in KHIN. And it's always been a conversation about whether something similar to that could be implemented for those providers that see Medicaid patients, that we could provide an incentive payment to them to actually participate in KHIN that would help to cover the costs that they incur associated with participating in KHIN. So that's been a long-standing discussion, is could we actually provide some incentive payments to those that are participating? And what we found is that the carrots are much more effective than the sticks. So, so some sort of penalty has not been as effective in getting folks to participate as being able to provide incentives.
So this is Denise. Can you guys hear me okay?
Yes, can hear you. Thank you,
I
Denise.
switched mics. So I really like that idea, and I like the idea of the incentives. My question is to you, Laura. I know Lacey is also a health information exchange used in Kansas. So where does that fit in with this recommendation? Should we be specific and say KHIN, or should we just broaden it to say participate in a health information exchange?
Well, for those of you who aren't familiar, there are 2 health information exchanges licensed to do business in Kansas, KHIN and Lacey. Lacey predominantly serves the Kansas City metropolitan market, and KHIN serves the rest of the state. KHIN and Lacey are connected to each other. So if you query in KHIN for a patient that's gotten care in let's say they were at North Kansas City Hospital or they were at Truman Medical Center, you'll be able to pull that information back from Lacey into KHIN and vice versa. If you're using Lacey, you'll be able to pull KHIN's data back. And so I would say if what we're really focused on here is treatment, right? If what we're focused on is treatment at the point of care, both exchanges do that equally well. There's not any question about that. If we move our considerations to other data acquisition and data visualization and data uses, for example, Kyle mentioned alerting. If we want to alert a federally qualified health center or United Healthcare, for example, that their patient has been admitted into the hospital, I can't alert on Lacey's customers. I can only alert on the customers that are part of the KHIN network. For example, we currently provide to Medicaid a consolidated CDA, that stands for Clinical Data Architecture, but what that is a document that includes all of the historical information about the Medicaid patient, as well as a daily update regarding any additional care that the Medicaid patient has received in the last 24 hours. So if the patient is coming in through a Lacey facility, I don't have the ability to provide that to Medicaid because that data is being stored at Lacey. So I think that it is important to define what it is that we're trying to accomplish with this system that we're creating. If it's just for purposes of providing good care to the patient at the point of care for treatment, KHIN and Lacey do those equally well.
So to jump in there.
Sorry, I had a question for Laura. And we haven't talked about substance use. Are there substance use providers that are using KHIN? Are there obstacles for them with CFR 42?
There are. We do bring substance abuse treatment information into KHIN. That data is blocked. Patient gives specific consent at the point of care for that information to be released. Or if the physician determines that it is a life-threatening situation and overrides the security on KHIN to be able to access those records. That does happen. We do see situations where physicians do override the security in life-threatening situations. We run an audit every day to determine if that is indeed taken place. If it does happen, we contact the compliance officer at the facility in which the physician worked and did the override, and we contact the behavioral health facility associated with the patient, behavioral health / substance abuse facility associated with the patient, to let them both know that the security on the patient was overridden because of an emergency situation that did not include the patient giving consent.
Thank you.
So thank you for that great discussion there. I think we talked through several different barriers that the group could consider addressing with this recommendation. I've attempted to type on the screen here, and I'm assuming I'm wrong, so please correct me. I've tried to capture what I was hearing, which was, it sounds like there's interest in a carrot and incentive to incentivize Medicaid providers to participate in health information exchange. I kept it general. It sounded like, Laura, based on what you were talking about, but by health information exchange, we were referring to both Lacey and KHIN. What changes would you make to this revised recommendation?
I don't have any changes to the recommendation. I think that was a good point, Denise, to kind of remind everybody that there's 2 health information exchanges, and, we needed to include both of them. They may not have the same capabilities, so one may be preferred eventually because of the functionality of their systems over the other, but that's not for us to make that decision. What I would say is that utilizing Medicaid funds to provide incentive to providers, I don't really have a big problem with that. It is still going to be predicated on the ability of the providers, or whether the provider has an EHR into their office or not. And that is, for some offices, it's a big cost. The bigger the office, the less the cost is, because you reap a lot of benefits. When it's a small office, you're going to have less benefit from having an EHR, and that's going to be a barrier. So, I would like to stay away from mandating that people that are seeing Medicaid patients, or whatever, participate into an EHR, because it would be, or participate into one of the health information exchanges, because that may kind of cause some network erosion, and some people basically dropping because, I don't want to do this, and I'm going to be dropping out of Medicaid. So I would strongly oppose that, because we're having, a very hard time maintaining our work network the way it is, with providers that are accepting low rates and all kinds of other, administrative burdens. So I don't want to put anything more. So any recommendation that would put something more on the providers, I'm going to make some strong recommendation. We don't even entertain them.
Thank you.
Chris, this is Andy Brown with KDADS.
Hi, Andy.
I'm just curious, do you feel like that is something that is going to be ongoing over the next 10 years? Or I mean, because that's what I'm trying to figure out here. We're trying to come up with a 10-year plan for modernization.
Okay.
So basing what your recommendation is on the ground today with care.
Yeah, I don't think that there's going to be a huge change unless, the EHR become so, it's just like Microsoft when you buy a license for $50. No, I'm not seeing that happening. I'm hearing from providers' offices that an investment into an EHR is a pretty significant enhancement. I don't think that we need to abandon the recommendation. All I'm saying is that we're going to have I think Laura was citing some like 60% or, something like this. We may make some progress into the participation because more offices are, buying EHRs or being able to participate into the health exchange information. But long term, I'm not seeing a really quick change into providers suddenly investing into this system. And maybe Dr. Berg can have a different opinion on that. I don't know.
No, I agree with you, Chris, that it is a hefty investment, especially for those smaller ones. And it's difficult for them to get something that is affordable and is quality. I've heard stories of really poor EHR systems that have created more problems and headaches than they've actually benefited from. So yeah, I agree.
And that is exactly what I've heard too, which in the smaller offices, it was such a change into their business practices that they had to do, where they had to retrain staff, they had to retrain their workflow within the office, and everything that there were very few benefits for them and a lot of hurdles. And so now I don't know how I will check that. I put a note to myself with the HIE, the Health Information Exchange, funding opportunity at the federal level. I don't know if this is all of the money is gone away or if there are some opportunities there to actually, assist some of the providers, to move toward an EHR. But I think there was an initiative at one point in time. Some of the providers took advantage of that and got actual benefits and some funding to compensate them for the investment that they were making through incentive payments, basically, that were built into the law. And but even with that, some of the offices said, the money that you're going to give me is not worth, the effort that I'm going to have to put in a disruption to my office.
And I think to supplement that a little bit, Chris, behavioral health providers didn't have access to that federal pot of money. For reasons passing understanding, they exempted behavioral health. Now, I think that has come around in the last couple of years, so maybe there is some funding available, but it would almost be easier. I mean, I think the idea of, I completely agree with you, by the way, that mandating any Medicaid provider to be on KHEN is much more likely to be a disincentive than it is to be a carrot, like what Laura was suggesting. So I would almost rather see a recommendation of $800,000 to $1 million be available at KDHE for a grant program to incentivize either some combination of purchasing an EHR and the first year of subscribing to or being a part of KHEN, so that people understand what the intent is. And I think child welfare providers are actually another good example of this. I mean, most of the child welfare providers I know of have robust electronic medical record systems already. But if you don't have something in the budget or access to funding, then, and that's a very vulnerable population on the BH and primary care side. So we would be smart to want to have them involved. But, if someone said, yeah, in the future, getting the CMHCs or others who are already licensed by the state, and they just need the additional couple $100 or something like that to be incentivized to get on, I don't think that that's as much of a barrier. But you're right. I would certainly encourage, if the word mandate is used, then I would encourage it to come out under Denise Sisman's name.
This is Carly at KHI. That seems like a good a point as any to jump in, Kyle. Want to quickly, two things, offer a reminder to folks, try and state your name each time you're speaking, just to comply with the requirement there for those listening to the live stream. Secondly, just in the interest of time, there's a number of great recommendations to get into. I wondered if we could quickly come up with a score. We've had lots of great discussion here. All of it has been an added value. If we could quickly come up with an ease of implementation score, and then again quickly an impact score. for this recommendation. We're not counting boxes or tallying. This is a judgment call of the group. A high scored, so a recommendation that has a 9 or a 10 in both categories is likely to be considered a high priority. So something that's very easy to implement would be a 9 or a 10. Something with a very high impact would be a 9 or a 10, just to give you a sense of the scale there. Anyone willing to toss out an initial number? How would you score the ease of implementation of this revised recommendation?
I would say 9. I mean, because there are a lot of folks doing it already. So it really is going to just be an EMR assessment and then the funding and connectivity to KHAN. But if others have, I defer to others on it.
I would go a little lower than that because we only have a 60%, so I would go with a 7 or an 8 because, it's going to take some time to actually get these, the 40% that are not there, basically. Also in the recommendation, the additional text that you just added, I would put initial participation in either KHAN or LACI. Both of them, because they're both part of the process. So that would be because of the number of people that are not on an EHR right now. And I may change my mind if we're seeing that the volume may be big, but it's only small offices in the areas where you have a lot of beneficiaries, because then you may have maybe 10 providers, but they're only seeing 10 beneficiaries, where here you may have 5 providers and they're seeing 2,000. So I don't know if I'm making clear what I'm saying about it all depends on what that 40% represents. If it's 40% of the number of providers, but the number of people that these providers are serving is small compared to the other 60%, and they only cover maybe 5% of the population when we're covering the 95% with the rest of the 60% providers, then I think you're right, Kale, that would be a 9. But I don't know that. I don't know what that volume is.
To kind of compromise there, I'm going to split the difference and pencil in at an 8 in between the 7 and the 9.
That's good. That's good.
Great. And then would pose the same question for potential for high impact. As we're thinking about what it would take to have a modernized behavioral health system, this recommendation as revised, 10 is very high impact. How would we score this?
Can I ask another question to Laura about this, that it does reflect impact? So there's one thing in terms of being linked and participating in KHAN or LACI. There's another to use it the data on a regular basis. So is it your sense that most people who participate, or most providers who participate, are readily accessing the data as they're treating their patients? Or is there a need for us also to think about how can we support use of the data from KHAN or LACI?
Denise, I think that's an excellent point. What we see in healthcare providers is a large amount of turnover. And so we'll see doctors, behavioral health staff, initially trained on how to use KHAN, and we'll see them, really utilizing it, excuse me, to a high degree. And then we may have turnover. We need to do new training. We have 2 HIE workflow specialists on staff that really go out and work with different providers in being able to use KHAN effectively. But education and training is always a critical part of the work that needs to be done, just because of the turnover that we have in healthcare in Kansas.
Sandra, I think, Laura, you bring up a good point, in that keeping this front and center for providers is going to be important, because if it's not, it's going to fall by the wayside, either through lack of training or awareness that it's available.
Yeah, and I think very, very, very good point, Denise. How people are utilizing it makes it either effective or not. So I think we need to make sure that, it's easily accessed, that the information is organized in a manner that makes sense to the provider's offices. And so they can see this actually as a good resource and as was another thing that they can access quickly, have accurate information, timely information, and all of this stuff. And it just becomes part of that's part of their protocol. You know, every office has those protocols that their staff follows. And we just need to do, and I don't know how we do that, but I'm sure somebody has a bright idea about this, is we need to go to these offices and say, how can we help you change your protocol without, you know, making everything else so difficult into your office to incorporate this? And what does it need to be looking like so that it's useful for you? So I think that participation and involvement of the providers' offices, hospitals, you know, clinics, you know, whatever, because they're all a little bit different, is going to be very important into us actually selling it to the provider population and say, this is a tool for you. This is a tool that is going to be so useful for your malpractice, for your this and that, because you're going to have that information. You're going to make better decisions, you know, and all of this. So there's that piece of the marketing that also needs to be taken into consideration as you're deploying this and whether you're going to have a high impact or not. Because it all depends on whether it's going to be taken up at the provider's offices or not.
Mm-hmm. This is Denise Sisman. Then I think given this discussion, I would give this a high impact score of 9, because I do believe it's definitely a high impact. And if it needs sort of that continual nurturing and training, then it's something that that this recommendation would help us to achieve.
Thank you, Denise. So I've marked a 9 there. I'll pause to see if there's any disagreement there, but I think I'm generally seeing nodding heads. So with that, I'll move us to our next recommendation. In the interest of time, we've skipped a page here. So the next recommendation is related to demographics. I'll give you a moment to read the recommendation on the screen, but the kind of first key question is this recommendation or some version of it an important part of what it would take to modernize our behavioral health system?
Denise, this is, or Carly, this is Laura. I'm not sure I understand this. Could you maybe explain it a little bit?
Yeah, this was, I believe, from the Crossover Youth Working Group, and they wanted to, it looks like, gather more information about primary language and geographic location of youths, I think specifically with the unique set of needs in that crossover youth population.
This is Sandra. This one seems almost at a micro level. Yeah, it's interesting to gather that information, but then what do you do with it? I mean, what's the impact it's going to have on the system?
I wasn't on the Crossover Youth Working Group, but as we talk right now about whether it's racial disparities or poverty issues, I think that that's one of the benefits of this kind of thing, is being able to see that there's a large number of people in the Laotian community in Wyandotte County. And that helps to gear our care coordination activities or case management activities if we have a better understanding of languages, cultures, and where those are at geographically. Certainly Southwest Kansas is another example. So how to gather that information is something that I would anticipate, well, that information and how to gather is something I could envision coming up even in the policy and treatment work group, but of this committee, but even future task forces and councils and commissions and things like that. I don't know if they're getting into it in the Criminal Justice Reform Commission, but I'd be surprised if they aren't. So that's how I saw this. It's just a matter of whether it is something that can be measured and put into something, but I don't know if it's something that's put into most EMRs that then KN has that information or not, Laura.
Well, we certainly gather primary language, we gather ethnicity and race, we gather geographic location, of the individual's address or where they're currently living. So if what we don't gather is what is their involvement in the juvenile justice system.
Sure.
So we would not know that. But if you had, for example, a list of individuals that you wanted to look at in terms, with de-identified data about those types of demographics as well as their geographic location, that data would be available. You could run a report de-identified to be able to get this information if you knew who was involved, if we could somehow identify who's involved in the juvenile justice system. So we're not going to know that.
What are thoughts here? Are we striking this recommendation, thinking that it's too zoomed in for the kind of task that's been given to this group when we think about modernization? Or are we interested to make a modification to it to kind of speak to Kyle's point about recognizing the importance of some of this information and in providing appropriate care?
This is Elizabeth Bishop, and I can see the value in having this information, but most particularly, for instance, for law enforcement, for planning purposes. In Sedgwick County, we have what we call CIT creams, crisis intervention teams, and that includes both law enforcement and social work, mental health specialists that handle a fair number of the calls, and it seems to be growing. I can also see it being valuable for as an interest to education planning. So I think it's valuable. I don't know how high on our priority list it should be.
From a healthcare standpoint, I just see that the potential for ComCare to be able to print out in Wichita the number of people that are in KHAN and maybe speaking Spanish or other languages could be really valuable. I understand the importance of law enforcement. I don't disagree at all, Representative, but that may end up being a different database. If we were going to include something like this, I would expect it would be much easier to try and put into the first recommendation as an extra, as an add-on.
This is Sandra, Kyle. I was thinking the same thing, that this could roll up into the previous one and just expand the previous recommendation to make sure that these things are included as a reporting mechanism.
Yeah. And we already gathered that information, so it shouldn't be it shouldn't change the rating or anything for the ease of implementation or anything of the first recommendation. And I can see where you're going, Representative Bishop, as far as having the information, across discipline, but I don't know how under the HIPAA and everything we can have education or law enforcement access that information whatsoever. I mean, they don't access the KHAN information or any of our treatment or, databases or the CMHC information or anything like this. I understand the value that it would have for them to know that this child has some mental health issues and should be treated differently, maybe in a system or as a first intake or whatever, but I can't imagine how we're going to take that barrier down. It's a federal barrier, and I don't know. I may just be narrow-minded here, but I can't see how we're going to accomplish that if your plan is to include access to that information to law enforcement, schools, education, or this kind of outsiders. To me is what I would qualify them.
but Chris, you're not making, I don't think, a different point than what Representative Bishop is, just in terms of it relies on the partnerships at the provider level or even at the MCO level to be able to say, hey, we're seeing an influx of, 30% more German Mexican migrant workers than we saw last year, who also they can't read or write Spanish or English, but they can talk Spanish. And so those are things that law enforcement will realize pretty quickly something's changed. But our partnerships with them, and I've had this conversation recently with the media when, all of the defund police stuff got started, we have really good relationship. Kansas is a different place in terms of the relationships between healthcare and law enforcement, whether you're talking the hospitals, ERs. I would suspect a lot of the safety net clinics work pretty closely with law enforcement, Denise, and we're that way. So if we're getting the data and then we can share it by just talking about percentages,
Okay,
then
I get it.
that's the other way around.
I get it. So it would be more like a statistical thing that we would be coordinating with the law enforcement or anything, not access to this, Yeah, okay.
I think that's right.
Yeah, okay, I'm fine with that. I misunderstood what we're trying to do here. Thank you. Thank you for the clarification.
Great, and thank you for that discussion. I've made note to add into our first recommendation the importance of some of these demographic data points to be sure to be included there. Before we move on to our next item on the agenda, did have one other task that I would like us to take a stab at excuse me, I have to start a new screen share here. Want us to take a stab at related to the existing topics here. And that is, here we go. Looking at the crosswalk of our recommendations on the screen here, want to flag for the group that several of these are quite similar and would like to get thoughts from the group on how these related recommendations should be considered by this group. Flagging them in purple on the screen here. All of them have something to do with data collection, kind of more epidemiological surveillance data collection. The Substance Use Disorder Task Force wrote about it, particularly in regard to KCTC and YRBS, changing that, moving away from opt-in consent to participate in those public health surveys. Governor's Behavioral Health Services Planning Council made a similar recommendation in a couple of different instances. So my first question to the group, considering all three of these together, this kind of common idea, is this change important to a modernized behavioral health system in our state?
This is one that I feel is a really high priority. As I recall, we talked about it on the mental health task force some too, didn't we, Denise? And Andy? And this is one of the things that I can recall. This is also something that could show up in the policy and treatment work group, but especially with what our suicide statistics are right now. This used to be a survey that you could identify hotspots by zip code or school district. So it does add a lot of information as relates to drugs, alcohol, sex, mental health. So it kind of covers the gamut, or covers the landscape. So I think that to add these things together, and there was a bill introduced that got out of committee in the House this year and then didn't get above the line on the House floor. But I think that it would be meaningful for it to have a high recommendation out of our work group and hopefully out of the work by the larger committee.
And this is Sandra. I think combining all of these into one makes sense.
And this is Denise. I totally agree. I also think this is incredibly important because we need data in order to determine what needs to be done. I wonder if I could ask the group to consider the Governor's Substance Use Disorder Task Force Prevention 5 also to be included, where it talks about collecting, analyzing, using, and disseminating surveillance data.
So the recommendation there, Denise, is incorporating language from 5 into how these would be combined?
Yes.
Okay.
And this is Laura from KHIN. I think it would be worthwhile to do an assessment of these surveys to determine which of the data is already available in KHIN. surveys are time consuming, expensive, and require a lot of kind of boots on the ground work. And we were contacted this year by Congress to see if we could actually replace the BRFSS with data from the health information exchanges. And there is a active study now that's being conducted to try to look at a way to reduce the actual use of, manual surveys, calling folks on the phone and actually using the data that's already being collected by the health information exchanges. So it may be something that we could at least think about as we move forward into the next 10 years. We'd like to move away from doing manual surveys.
This is Sandra. This has been years ago when I would work with the Communities That Care survey, but it collected attitude towards substance use, all the things that Kyle listed. So I wouldn't want to lose that. I agree. Surveys only get us so far, and people get surveyed. I get multiple surveys a day. So if there are things that we can pull out of KHAN, that would be great, but I don't want to lose that piece that gives that perspective from the surveyee.
Yeah, I would agree. And I think that's really what the message has been. If you can get the data in another way, get it. But there's things that you are going to have to actually discuss with a person to get the information.
I agree with that. I think to some extent too, some of these surveys would give information for individuals or children that are not seeking care right now. So I love the idea of assessing what we have and how we can use data in different ways.
Great, thank you for that discussion. We'll work to combine those four existing recommendations, and we'll share that back with the group for review. At this point in our agenda, we still have a number of existing recommendations, and what we'll plan to do is assess some of those via follow-up survey, where your responses will go directly to me, and then we will review those at the beginning of our next meeting for consensus. But wanted to be sure, make sure I have the correct document showing on my screen here. There we go. I wanted to be sure we had time to think about recommendations that have not previously been developed. So new recommendations that did not exist in any of the 5 previous reports. What you should see on the screen here now under barriers is the list of items you guys, this group, brainstormed as it relates to data systems, barriers that impede people from accessing the care that they need, or barriers to a modernized behavioral health system. I'd invite the conversation, I'd welcome conversation kind of anywhere on the list here, wherever anyone is interested to kind of jump us off with some discussion about what recommendations the group might be interested to consider to address any of the barriers listed here.
Carly, this is Elizabeth Bishop, and I would like to skip down to the EMR at state hospitals is outdated. And one of the reasons that I recommended that Chris join our discussion is because we have been attempting to develop a network that allows for rapid reinstatement of Medicaid eligibility for those in either prisons or jails, but including hospitals. And if that notification is not keeping up with what the system, what the network needs, that needs to be addressed. And I think Chris could fill us in more on that.
All right, took me time to unmute here. So currently we do have a manual process with the state hospitals where we have a contact over there and they have a contact at our place. And we do what we call discharge planning. So when they know that a person is going to be getting out of the hospital, they do all of the paperwork and all of the assistance necessary for them to be assessed for possible Medicaid eligibility when they're getting out of the hospital. And they do the same thing, you know, when they come now, when they're going into the hospital, I think there's a different process for that. But so all of this is really manual. It is not, it's not similar to what we have with APRIS, where APRIS sends us a basically an alert that somebody has entered or exited a jail. And that causes us to do the work on the other side to reestablish eligibility or stop, you know, the eligibility for the period of time that they're incarcerated. So it would be nice if we could have an automated process for the, you know, for the state hospital. But I wanted people to know that we have a manual process, and we have the same thing with a manual process also with corrections for the people that are entering the prisons, not the jails, but the prisons. And so those are manual systems, processes. So who is doing the RFP? All right, Angie, do you know anything about this? Is it KDAD?
It is KDAD. I don't
Okay.
know if he may be missing his mute button, but yeah, I think they're
Okay.
actually going to call it the Andy Brown Living Memorial EMR system at the state hospitals.
Thanks, Kyle. Yeah, we are currently working on an RFP for electronic health records at the state hospitals, as well as a replacement for our KCPC. So there will be, I mean, both those bullet points, the EMHR and the KCPC, both of those are currently in action, and I don't think need to be included in recommendations at this point.
Okay.
So we don't need to make a recommendation here, or is there interest from the group in saying something specific as to how that RFP should consider like automation of Medicaid eligibility reinstatement?
Yeah.
I think if it's already going to be put in, that's great. So it wouldn't hurt to keep that in the recommendation. I think that it gives the full committee and the legislature the understanding sort of what Representative Bishop's talking about. I think that conversation between whether it's the folks in the hospitals or the community hospitals or law enforcement or CMHCs, I think that's probably whatever you get as an EMR for the state mental health hospitals, you want it to look as good as it can now, because as quickly as technology runs and as little interest as generally, no offense intended to the legislators on, it just does not take a very high priority very often. I would argue that the current EMRs at the state hospitals are not much more than access databases on stilts.
Yeah, I agree. But I think adding the thing that it needs to support some interaction with other systems, just like the eligibility system, and there may be some other systems. So we don't want to, that I don't know what those would be, but maybe making it broader to being able to have, you know, interfaces or interoperate with other systems as appropriate, you know.
Yeah.
What other new recommendations is the group interested to spend some time discussing? I think we've addressed in some of our earlier discussion today, cost barriers to KHIN participation with the discussion of the incentives to offer new providers. So I'll cross this one out unless there's concern with that.
I'd like to ask a question about that. So the first recommendation, was it specific to children served in the foster care system? And if so, could we broaden it to?
I think on that, Denise, through our discussion, I think we were revising and I think how I had that written, it was broadened to be beyond just foster care.
Okay, great.
Youth, great, thank you. Another one barrier to specifically highlight, as it was referred to this group by the Policy and Treatment Working Group, was any interest the group has in talking about sharing or data management among prevention providers. How are they included in some of the systems we've discussed today, or how should they be included in some of the systems discussed?
This is Andy Brown with KDADS, and so when we were talking about the surveys, I would say the large amount of the data that's collected by the prevention providers, one source of that are those KCPC surveys, and then the other one is largely their process data that's collected at KU through the community toolbox.
Great, thank you.
Carly, this is Elizabeth Bishop again. I don't want to drag us backwards into the couple of the previous areas that we've discussed, but I am curious about the status of K-TRACS. I served on the Governor's Substance Use Disorders Task Force, and there was a lot of discussion of K-TRACS, and I am unclear as to the relationship between K-TRACS and KHIN. I know that KHIN includes pharmacy, and yet pharmacies are a bit of a problem technically. And I don't know if K-TRACS can fill that, or if it's going by the wayside, or where we stand with that.
Any working group members interested to speak to K-TRACS, K-TRACS funding, or the way K-TRACS complements other health information exchanges?
You know, I haven't heard that K-TRACS was disappearing. I think it's doing something a little bit different than what KHIN is doing. But I'd have to go back and, this is Chris Swartz, by the way. I keep forgetting to introduce myself every time I start talking. I will look into this and see what, but I think K-TRACS has a different purpose. And it's more targeted towards management of like substance abuse drugs and things like this are getting entered into that system. Then basically information that I would have to check into that and see where. I haven't heard that it was disappearing, actually. That funding was going away. I may be wrong.
Chris, this is Elizabeth Bishop again. As we discussed it within the Substance Use Disorders Task Force, it is used to perhaps pick up on doctor shopping, where a patient is going from doctor to doctor or from pharmacy to pharmacy. Yeah. But also used by physicians if they are concerned about something that they want to prescribe fitting with other prescriptions that the patient is getting. A doctor can tune into or log into K-TRACS and see the whole picture, is the way I understand it.
Oh, I see. So that would be, if they're ready to do a prescribe something, they can look and see what the drug, utilization of that, or the other prescriptions are to not have any contraindication, of certain drugs interaction.
And there was discussion of the fact that it's not utilized as much as it might be.
Yeah, and so for that purpose, I would think that the information on KHIN or the other health exchange system would have the same purpose, because you could access that beneficiary record. And once we pass the barrier of the pharmacy not being able, because they're all on the point of sale and, different things. And that's why they can't get their information into KHIN very easily. But once we pass that hurdle, then that single place would be available for either healthcare, dental care, mental health, pharmacy, and everything. So K-TRACS may by that time not have much of a purpose except for whatever else they're, fulfilling.
would like to hear from others in the group. Is there interest as it relates to data systems to make any recommendations around K-Tracks?
So this is Andy Brown with KDADS, and while K-Tracks is a Board of Pharmacy program, and I think KDHE is pretty involved in it as well. One of the primary interactions that we have with it in behavioral health is through the 1115 waiver for the SUD IMD exclusion demonstration plan, and so there's a large part of our health IT plan with CMS that's connected K-Tracks in that regard. So I think, KDADS is always willing to advocate for securing ongoing funding for K-Tracks through state funding.
So what I'm hearing there is perhaps a recommendation to consider around ensuring ongoing state funding for K-Tracks. Unless there's any concern with making that addition.
Elizabeth Bishop again. I understand the need for that particular point to be made as in this place, but in order to ensure state funding, it's going to have to answer the issue of, is it duplication? Are there some things that are overlapping here that could be handled more efficiently? I don't know what the answer is. I just I'm wanting to point out that will probably come up.
Great.
Yeah, this is Andy Brown again with KDADS, and Representative Bishop, the K-Tracks program is our federally required PDMP program. So it's not duplicative in the sense of the role that it fills within the state. There may be some, fields and, things within the K-Tracks database that are duplicated within KHEN or some other database, but K-Tracks is our PDMP program. So it's a standalone in that regard.
Andy, this is Denise Sisman. K-Tracks is also accessible. Oh, well, I guess my question is, can law enforcement access data from K-Tracks, or is K-Tracks limited to providers?
So yeah, the access that people have to K-Tracks is fairly limited. And I do not believe that law enforcement has direct access without a subpoena, because it's all private data.
And on that note, looking at the time, it's 1:56. So I might stop our discussion on data systems there. I'll flag for the group that at our next meeting, the next kind of topic assigned to this group that we'll be diving into is the legal system and law enforcement. So I think law enforcement access to some of the information we've been discussing here today will be certainly a conversation that will be continued. On the note of next meetings, there's currently a doodle scheduling poll that you received from me the latter part of last week. If you could complete that or just double check that it has been completed on your behalf, if you have someone supporting your scheduling, we'll work to get our next 2 meetings scheduled by on Thursday of this week once we're through this round of meetings. So look for those calendar appointments coming later this week, and your participation in that doodle poll helps ensure that we have a time that works as conveniently as possible for as many of us as we can. With that, a couple other reminders for the group at this point. The special committee is meeting on Monday. So that's something that's likely on your radar for legislative members. Kyle, just to prime you all as our chair here, I'll likely be reaching out to you with a quick ask to provide a 5 or so minute update to the special committee on just what some of the group has covered so far, but I can get you more information on that as we get to the end of the week. Lastly, again, so our next topic that we'll cover is legal system and law enforcement. So we'll continue to look at the recommendations from previous reports. So I would encourage you to take a look at those related to legal system and law enforcement ahead of that next meeting. If there's any that you think have been already addressed, please feel free to send me an email. I'll cross those off our list, and then we'll have more time on the ones that we feel are most meaningful. Additionally, I think we have some supplemental experts to join our conversation on the legal system and law enforcement, who we'll be reaching out to specifically to get their participation in that meeting. But if there are other names that you think would be helpful to have kind of in our virtual room here as we discuss some of those recommendations, please let me know, and I'm happy to extend that invitation. With that, I think that concludes the items that we had on our agenda for today. I want to extend a special thank you to both Chris and Laura for joining us as our supplemental experts for the day. Your input was invaluable in helping us understand, some of the many data systems that support our complex behavioral health system in the state. So thank you.
You're very welcome.
Thank you.
Glad to participate.
All right. So with that, I will consider us adjourned, and keep your eye out for our next meeting invitation, at which we'll discuss legal system and law enforcement.
Thanks, Carly.
Thank you.
Thank you.
Bye, everyone.
Bye, everyone.
Thank you, Carly.
Thank you. Have a good week.